Welcome today to our pre-conference workshop on strategic and operational planning for global health security. This workshop is being hosted by CRDF Global. We are a nonprofit based in Arlington, Virginia, with a team of global health, with our global health team spread among multiple locations, including not only our Arlington office, but our team in Atlanta, our team in Amman, Jordan, and our team in Almaty, Kazakhstan. We are hosting this together with colleagues from the US Centers for Disease Control and Prevention, all of whom will be introducing themselves separately. I would like to remind everyone that we are all on a Zoom interactive meeting rather than a webinar. So when you are not speaking, please do mute your microphone to avoid inadvertently talking into a presentation. However, we do intend to be able to turn these microphones on later so that we can have interactive discussions. This session is being recorded and will be shared with participants and will be posted by CUGH to be made accessible. So I want to confirm that the session is being recorded and that your public chats and that your comments or interventions made during the session will be captured as part of the proceedings. I would like to thank CUGH for this opportunity to meet with you today and appreciate the chance to be part of CUGH 2022. Look forward to seeing many of you not only at our pre-conference workshop, but in the sessions during the conference. And with the housekeeping remarks, I would also like to remind everyone that in addition to being conscious about your microphone and keeping it off when you are not directly making a comment, that you are welcome at any point during today's conference, pre-conference workshop, to ask questions via the chat box by submitting your questions directly into the chat at any time, and the moderators will be watching the chat and collecting those comments and questions for the speakers. You are welcome during the Q&A periods to raise your virtual hand, and in Zoom, you do that via the toolbar at the bottom of your screen. So that we recognize when you have a question and can call upon you. And you are also welcome to go on camera and raise your real hand, and we will also try to call on you that way. But please feel free at any time during the conference workshop, the pre-conference workshop, to drop your questions and comments into the chat box, and they will be acknowledged by the moderator and shared, or to let us know via the chat box that you would like to make an intervention. So with those housekeeping remarks, I will introduce myself, and then I will turn over to my colleague, Jim Banaski, to introduce himself. And I apologize that I am not on camera to introduce myself. I will literally be on camera in 2 minutes. My name is Dr. Julie Fisher. I am a Senior Technical Advisor for Global Health at CRDF Global. I am delighted to be able to join you here today. My training is actually in laboratory sciences. I'm a microbiologist by training, but for many years have been working at the intersection of preparedness and high throughput.
Julie, we lost you for a second.
Diseases and epidemiology functions, and with their colleagues in public health emergency management functions, so that the information that is generated is useful for action. So that's my introduction. Delighted to be here today. And now I'm turning it over to my colleague, Jim.
Good morning, good afternoon, and good evening, everybody. My name is Jim Banaski, and I'm a Senior Technical Advisor for Global Health at CRDF Global. My specialty is public health emergency management and applying preparedness to planning and simulation exercises, plan development, emergency operations center development, I spent 28 plus years with the US federal government, my last 13 and a half before I retired at the US Centers for Disease Control and Prevention. Most of my time there was spent providing technical assistance to state and local governments, as well as in the international community for preparedness and response programs. My educated background is actually in environmental science, but I concentrated mostly on hazardous materials and hazardous material handling. I am also an adjunct instructor at Georgetown University, also at Emory University, and I served 11 years as an adjunct professor with Drury University, teaching undergraduate environmental law and environmental science. And we're happy to have you here with us today. And I will now pass it over to Luis Hernandez.
Thank you, Jim. Good morning, good afternoon, good evening, everyone. My name is Luis Hernandez. I am a public health emergency management technical advisor with CRTF. And just like Jim, I have a little over 22 years of experience in emergency preparedness and response, including emergency management. And the last 11 years was with the Centers for Disease Control and Prevention. And with that, I'm going to give the floor to Ashley Greiner, that she is going to give the first session today. Ashley.
Great, thank you, Luis. Hello, everyone. My name is Ashley Greiner, and I'm currently leading the Emergency Response Capacity Team at the U.S. Centers for Disease Control and Prevention. I'm an emergency medicine physician by training and have been working in the natural disaster and humanitarian response phase for about 15 years at this point, both in academia as well as working with non-governmental organizations. I've been at the CDC for the last 8 years and currently engaged pretty heavily with countries globally, about over 20 at this point, working on strategic preparedness, operational planning, thinking about how we can strengthen countries to be better prepared for and to respond to and recover from public health events. So very excited today to kick off this session with the first lecture. So I will take over sharing my screen, and please let us know if you have any issues sharing anything or seeing, sorry, my screen. All right, I'll just get confirmation you guys can see my screen.
We can see it.
Perfect, thank you. All right, so we'll begin here. So I am going to start by setting the stage for strategic and operational planning for global health security. There's a number of you on this call, and many of you may have some experience in this global arena of thinking about emergency preparedness and response. When you think about strategic and operational planning, it may not be that fast-paced adrenaline-like emergency response that you think about. Emergency preparedness often is a lot of sitting and working through documents and discussions and having memorandums of understanding to ensure that when you do get to that response phase, that adrenaline-inducing scenarios actually have a plan for how we move forward. And later, after this session, you'll be hearing a lot more about what that planning means and why plans are useful and why they're not useful sometimes. But I'm going to tie this into why are we actually talking about this today? Why is this even important? And so for the first part, I want to talk about the International Health Regulations, or IHR. So IHR, for those of you who don't know, is an instrument of international law that's legally binding for 196 member states. That includes countries and territories. They create the rights and obligations for countries that include the requirements to report public health events, which means they have to be able to detect them first, be able to assess the public health event, be able to report it back to WHO, and also be able to sufficiently respond to it. So you can see here that in this detect, assess, report, respond components, that you need a lot of procedures and processes in place ahead of time prior to an emergency occurring. And that's why the planning component is so critical. In terms of why this actually matters is that we have, as you guys all know at this point with COVID-19, we have health threats that have no borders. We have travel and trade that's happening all over globally that really enhances pandemic potential. We also have threats that are popping up all over the world day to day. Many you never even hear about, but many WHO hears about. And those are the kind of missed epidemics or pandemics that never happens because countries have built their capacity to respond to it. So you may not even hear about it in the news here in the United States. And the idea that this is multi-sectoral. So we are not just going to strengthen a country's ability to respond through their public health system. What about the Ministry of Agriculture? What about the National Disaster Management Authority? Whatever that may be. So for those of you based in the US, there are multiple entities, as you know, that are involved in response and come in at different times. If you're in other countries, you likely have a similar setup where there's one group working on one type of emergency, other groups working on other types of emergencies. But how can we bring all these sectors together so we have cohesive strengthening for emergency response capacity? And so the international health regulations do a really great job of outlining capacity areas that countries should be really thinking about when building up and strengthening their ability to respond to public health events. And so here are the major categories that you'll see in the international health regulations and in a lot of its evaluation mechanisms. So again, this is a legally binding agreement. This is back in 2005, and all countries have subscribed to this. And it looks great if you look at these areas, right? The idea that we have legal instruments, financing, you see surveillance on there, laboratory systems, human resources, risk communication. It really runs the gamut. The problem with the IHR is that although it's legally binding, there was not a lot of accountability for countries prior to 2014. When the West Africa Ebola outbreak occurred in 2014, it brought a lot of attention to the fact that most countries were not, quote unquote, ready. So that is really what this is about. And if you don't learn anything during the session except that strategic and operational planning is so critical for a country to be ready, that is a win for us because it's such a critical component. And I'm going to show you all of these technical areas that you see here. So regardless of your background or where you're coming from or what health program you're engaged in, this international health regulations framework is going to be critical to you, as well as its evaluation mechanisms, which I'm about to talk about. So the global health security agenda. So I talked about 2014 being a critical, pivotal time point where people had an opportunity to take a look and say, wow, we are not ready for what was going on in West Africa at that point with Ebola. And so this global health security agenda was born and was really a mechanism to help countries meet international health regulations, IHR, and created frameworks for countries to help have them discrete indicators that they could meet to and measure against to say, yes, we are quote unquote ready. This is a more updated version of the Global Health Security Agenda. So its most recent goal is shown here. There's a lot of words here. You're not meant to read it. The important point is to note that by 2024, we want more than 100 countries to demonstrate improvement in at least 5 technical areas. I'm going to talk about what those technical areas are in a bit, but you just saw them on the previous slide, right? So that could be the ability, demonstrated capacity in laboratory, demonstrated capacity in surveillance, zoonoses, etc. So in 5 of those technical areas, we need to have demonstrated capacity, and we want that in more than 100 countries. So how do they think that countries are going to go about doing this? There are these global health security evaluations, and there's a few of them. The one I'm going to focus on for the purpose of today's discussion is the joint external evaluation. And again, I'm just giving a broad overview. We're going to dive into planning in a bit, but I want to make sure we're all on the same page so we understand what we're talking about when we're talking about planning and how this fits into the overall picture for global health security and international health regulations. So these joint external evaluations are voluntary, and they don't happen at repeated rhythms or cycles. They're ideally supposed to happen again and again after the initial joint external evaluation, but they are voluntary. So countries actually have to initiate that process to have that start. There are a number of other ways we evaluate countries to see if they're quote unquote ready for a public health emergency. And you can see them here. There's a state party self-assessment annual reporting. That's mandatory and it's done by the country. The joint external evaluation I'm going to talk about in the next slide. And then there's also after action reviews, which are usually occur right after a real world emergency has been faced by that country, as well as simulation exercises, which are a way that we can actually test certain capabilities in a public health system prior to an emergency occurring. And overall, the results of all of these can actually help guide a country in developing their national action plans for health security, thinking about strategic planning and operational planning for their different health programs, et cetera. So let's focus in on the joint external evaluation because we're going to talk about that throughout the next few hours. The joint external evaluation, if you don't know what that is, as I mentioned before, it's voluntary. So the country volunteers for a joint external evaluation, which is the first point on the left. Then there's some self-evaluation that then occurs by the country. A joint external evaluation team is identified, and the key point there is external. So these are external partners coming into the country who are subject matter experts within their field, and they do the assessment of the country. So now you have a self-assessment and this external assessment. And the joint external evaluation team, the JEE team, then drafts a report. The report is posted, and these are actually public. So if you wanted to go today, you could go and take a look and actually see what the joint external evaluation report is for the US. You could see what it is for Ebola, et cetera. You can look at all of these different countries. And the idea is that from this report, WHO and others help the country develop a roadmap of how to address the gaps that are found in the joint external evaluation. And that fits into the overall plan or national action health plan for that country. All right, so that's a brief overview of joint external evaluations. There are people who it is their full-time job to study the global health security agenda, to study IHR, to study JEEs. We are not going to go in any more depth today, but I want to make sure we all understand that because we're going to talk about how this fits into planning and why we're here today. So on the next slide here, you're going to see a bunch of different technical areas that are outlined in the joint external evaluation, the JEE. And so you look at this and you're probably thinking about, where do you think planning is in this? Well, the obvious part would be to look here. Emergency preparedness, emergency response operations, right? We're here to plan for emergencies and public health events. This is the obvious place where you're going to find planning. And you're right, absolutely, it's absolutely there. It is actually, though, more discreetly indicated in a completely different section under prevention. So it is a prevention indicator, and these are quotes taken from the updated guidance that is soon to come out in the next few months. And there's an actual indicator that says strategic planning for IHR, preparedness, or health security. So now there is a concrete indicator outside of emergency response, but just planning in general for preparedness in a completely different category. And you can see here that, again, they're talking about those national action plans for IHR. And so this is a critical indicator that countries are going to have to measure themselves against. So again, going back to that figure, is there planning and emergency preparedness and emergency response under respond? Absolutely. But it's also here. And the other thing to keep in mind is it's actually everywhere within the JEE. You can look in any of these different categories and you'll find it under, you'll find financial planning, infection prevention and control planning, RCCE planning, contingency planning, workforce planning, One Health planning. Plans are in everything, and they talk about strategic planning, operational planning, standard operating procedures, policies, etc. This is sprinkled throughout the joint external evaluation. So again, just underscoring how critical this topic is, because if you work in a lab, if you work in surveillance, maybe you're a researcher, thinking about the country's ability to plan for a public health event, regardless of where they're coming from, either from the financial, budgetary system, or thinking about One Health, there needs to be a plan in place. And that is so critical enough that you will find planning sprinkled throughout the joint external evaluation. So what does this actually mean? And how do we do the joint external evaluation? What does rating a country on capacity actually mean to show readiness? So as I mentioned before, these are the joint external evaluation capabilities. And here we have emergency preparedness and emergency response operations. So just like the last few slides. But what you're seeing here is actually an assessment done of the WHO Afro region. So this is the African region, which had, I think at the time that they did this, about 80% coverage, meaning about 80% of countries on the African continent had conducted a joint external evaluation. And I'm not going to go through all of this, but just know that red is bad, orange is okay, yellow is a little bit better, and green is great. Green is they have demonstrated capacity. They are functioning at where they're supposed to be for capacity. And what you're seeing is percentages of countries. So these are percentage of countries within the African region. How many percentage are in red? And you can see here overall, we have very few countries that are green. We have none actually for in terms of percentage for green for emergency preparedness. And we only have a few here for emergency response operations. Most are in this orange, which is a little better than nothing, but it's still not where we need for having capacity. And remember, our goal is by 2024 to have 100 countries here in the green. So this is what we're aiming for here. But you can also see broadly, outside of just the emergency lanes, you can see under legislation, coordination, zoonoses, food safety, points of entry, across the board, people are not doing very well. We seem to be doing all in immunization and surveillance as the primary areas. But again, I'll underscore for you, even though I'm highlighting just these two indicators, remember, planning is actually up in legislation, planning is in coordination, planning is in acute microbial resistance, planning is in zoonoses, et cetera, et cetera, et cetera, et cetera. So just know that although we're going to be focusing on the emergency sectors, and there are two big indicators that encompass a lot of the work that we do, that the fact that planning is actually part of all of this. So I think I beat that into everyone at this point. So we're going to move on to talk a little bit about the scoring. So I'm talking about this because, again, I want you to understand where we need to start concentrating our efforts for emergency planning and for thinking about strategic and operational planning in general. So you can see here, these were the JE scores from 2016 to 2019. We see green again is good, red is not so good, yellow is a bit better. And then blue, you'll see here are ones that have been completed, but we don't have the results yet. And then in gray, you can see overall where JEs have not been conducted. So you're looking at this and you're like, okay, yeah, no, that makes sense. This, it makes sense maybe that this is a 4, and okay, I could see how this is, 2 to a 4. And it looks like the US is a 4. But take a moment to think about how people did during COVID-19. How did people perform? Many people would say the US did not do such a good job. And so for this to be a 4, what does that actually mean? Does that actually mean we have the capabilities to respond to a large public health event? And so there's some issues with the joint external evaluation. It's going through its revision. It's coming out with a 3.0, but really thinking about the types of emergencies. So is one country that's currently a 3, is it always a 3, or does it do really well with natural disasters versus an outbreak? What are the differences when it comes to types of emergencies? And then also thinking about scale. So thinking about the scope and scale, and many of you guys know what outbreak this is, but this is COVID-19 as it's spreading back in January 2020. Maybe people deserve a 3 or deserve a 4 for outbreaks that happen at their subnational level or happen within their borders. But when a system quickly gets overwhelmed, is that 4 still accurate? And so thinking about the scope and scale for these joint external evaluations is very difficult. And can we actually say someone's a 1, a 2, a 3, or a 4 without taking into consideration really, again, the type of emergency and the scope and scale that we're facing? The other thing, and the joint external evaluation is doing a much better job of this, is thinking about preparedness, planning, and operations at all the different levels. So noting that there's always going to be a local level in an emergency. There's going to be a subnational level, a national level, and then maybe the regional and global response if it gets big enough. So understanding too that there's all these other benchmarks that can contribute to a way a country is being scored. And the reason I want to talk about this is because as countries start thinking about emergency preparedness and they look at their risks, the hazards that they're going to be facing, their current capacity to respond to it, and they think about the planning that's going to lead to implementation, that planning component needs to take into account everything we just talked about. It needs to take into account the scope. It needs to take into account the types of emergencies the country is going to be facing, as well as its capabilities to actually respond when that emergency occurs. And so planning in itself is one component of emergency preparedness process, but there are many, many different components that makes up the planning process. And that's strategic planning, we have operational planning, there's contingency planning, tactical planning, policies and standard operating procedures that all need to in place to ensure that a system is effective and efficient when it comes to a public health event. So again, this may not be the adrenaline-inducing aspect of emergency response, but this is the most critical component for a country to actually be prepared for when that emergency does occur. And that's also considering these plans under preparedness, response, recovery, and mitigation. And I would say most of the time, we get our requests for emergency preparedness during response and recovery, right? This is when a country realizes or a government realizes, wow, we do not have the capacity. Our goal in working with you all today is to talk about strategic and operational planning, to hear from some of you who have country examples or worked in this area, to hear questions you have, to talk about best practices, to talk about challenges potentially that you could face, all so that we avoid realizing the need for this during the response phase. And that we have sometimes the luxury of time during preparedness and mitigation to actually put some of these measures in place so that a country is strengthened to be able to effectively respond to an emergency. And so that's going to kind of tee up our discussion for the rest of the day. But now I'll take a moment and hand it over to Mr. Banaski, who will go on to talk a little bit more about planning specifically. So thank you all very much.
Okay, thank you, Ashley, for setting the stage for us. And as we move into the next section, it's actually a great stage setter for us. As we, and are you able to see that part of the screen?
Can't see it yet, Jim.
Okay, for some reason I am freezing up here a little bit. Hold on. There we go. There. You see that now? Perfect.
Yes.
Okay, so thank you, Ashley, once again for setting the stage for us as we get ready to move on with our program, because it really does set the stage. A lot of times we are faced with the discussion of, how do I do this? Where do I start? And as Ashley described, the evaluation process, singling in on the joint external evaluation, that's kind of where I wanted to start with, is how do we get this moving? How do we get this started? So what you're seeing now is a presentation on really just linking these an evaluation process to our planning process. As we said before, you know, planning isn't exactly the most exciting thing in the world. I can tell you, over a majority of my career, I was not a planner. I was a self-proclaimed doer. I spent most of my time out in the field or out working with others, building capacity, just not really planning. Until I really kind of stepped into some roles that led me on more of a national response footing, having served in Hurricane Andrew relief in 1992, all the way to Hurricane Katrina in 2005, the Deepwater Horizon oil spill, the tsunami and nuclear disaster in Fukushima, all the way through Ebola, Zika to COVID-19. And one of the things that I learned kind of the hard way was, as Sir Winston Churchill said, "He who fails to plan is planning to fail." And I think, even as Benjamin Franklin said, if you fail to plan, you are planning to fail. So it is quite obvious to a lot of us, and as Ashley pointed out when we talked about COVID-19, just because you have an evaluation score that may be high doesn't mean sometimes that you're practically prepared and fully planned in order to respond to some sort of disaster. So what we're going to do today is talk about strategic planning and how do we get there. From the Scandinavian Journal of Public Health, this quote was great. It's, strategic planning includes all measures taken to provide a broad picture of what must be achieved and in which order, including how to organize a system capable of achieving these overall goals. Strategic planning is often done to prevent based on previous experience and expertise. So here is what is typically included in a strategic plan. We have an executive summary. We have an introduction, which contains everybody's favorite part, which is that mission and vision, the strategic goals, which lead into objectives, and what I consider probably the most important part of this, which is the performance measures. These are year 1, 2, and 3. When we were talking about order, you don't just jump right into the end of it and say, we're going to have a completed plan this year, because as we'll talk about further, both in this presentation and in our main presentation later, there's a process that you need to go through. And when you work through a process, you'll find that there are certain steps that you have to take and certain milestones that you need to hit in order to have a product that will give you what you're really looking for, which in a lot of cases is that roadmap. Ashley had mentioned the national action plans, that come out of the joint external evaluation process. That national action plan for health security is often seen as a version of a strategic plan, or it could be, because it outlines certain goals and objectives that you want to do. But in some cases, these national action plans also carry an operational flavor to them. So what we're talking about here is based more on US doctrine. Many of you who will or are in the academic community or students end up working in global health or in public health in the United States. In the United States, a lot of this is laid out for you. Globally, it's not. So one of the things that I have tried to say over time is, if you are starting out in your career or if you are trying to get into this field, understanding domestic doctrine helps you internationally, because often we find ourselves in countries that have not used any type of process before. And so sometimes just understanding domestic doctrine gives you a place to start, or it gives you some ideas of how to align what the country is currently doing and where you're hoping to help them build capacity into a program that can exist over time and that's sustainable. And the last two parts of this plan, one of them is implementation and maintenance, which is how are we going to actually implement this plan, and how often is it going to be updated or maintained, and who's responsible for doing that? And then, of course, a conclusion. One method to get a starting point is to include your joint external evaluation results. This is not the only method. It's not the method. It is a method. If you are struggling with that question of where do we begin, here's a great place. Often when I'm asked to start to work in a new country, the first question I ask is, have they completed a joint external evaluation? And if they do, it gives a pretty decent snapshot of where they are in certain areas, including recommendations. And sometimes those recommendations are what we can use in order to get us started. So as you see there in the second bullet, for public health emergency management, the Joint External Evaluation 2.0, which was published in January 2018, has two primary areas for us that we tend to concentrate on: emergency preparedness and emergency response operations. As you saw with Ashley's presentation, there are quite a few areas in different themes: prevent, detect, and respond. Most of what we do in preparedness and response deals with these two areas here. As the new guidance comes out, I'm really looking forward to an expansion of planning and how do we handle planning. But under the JEE 2.0, under emergency preparedness, which is known as Respond 1 or R1, it has a question in the tool bank or the question bank that's used during one of these evaluations. And that question is R1.2.2, which asks, does the country have a multi-sectoral, multi-hazard emergency response plan? Now, this can be important because when we talk about multi-sectoral, multi-hazard emergency response plan, one of the things that we face when we do these joint external evaluations, and I had just happened to have the pleasure of serving on one of these teams in a country in Eastern Europe. And the question dealing with these plans can be taken two different ways. One is, does the health system or public health world have these plans, or does the nation have these plans? So in this case, we're concentrating strictly on the health system or the public health realm when we talk about emergency response planning. So this is just an example from what I will call country X, but this is from a real joint external evaluation, one that I participated in back in 2019. And as I said, when we get started on one of these capacity development jobs, or to look at what has been done in the past, we often look back to the JEE. So the question I had asked from the very beginning was, had this country done one before? Because as Ashley said in her presentation, these things are not meant to be one-offs. They're meant to be done periodically to help update where we are with a good snapshot of the overall system. So in this case, they had not created one, but some of their recommendations and some of their programs were actually modeled off the earlier version of the JEE. So when we asked them to do their self-assessment, which was based on 2.0, some of the information we got was actually based on answers from questions from 1.0. So while there are not a large noticeable differences, there are some significant differences between the two. So if you're using this and you're using old data and new data, just make sure that the data corresponds with the right version, because that can throw you off a little bit. Some of the observations from that in-country review of this country X was that only some lead agencies have emergency response plans in line with their functions under the National Civil Security Plan. So when we reviewed the National Civil Security Plan, this was another question that we didn't quite ask properly. A lot of it was classified, so they wouldn't let us look at some of those. But the ones that they did let us look at, we could see that there were some severe gaps in the response plans. And also, there was a shortage of staff in the responsible agencies to develop and implement these plans. As you can imagine, planning is a wonderful tool that puts people from different organizations together before an emergency and lets them talk, lets them develop policy, lets them work through different scenarios. And we often say that the planning process sometimes is more important than the plan itself because of these relationships that you build. Well, the problem is when you have such a shortage of staff, there's not a lot of emphasis placed on planning, in my experience. So this tends to lead to gaps and missing items in response plans, plans that are not cohesive, that you don't see, lots of things together. So it just is kind of disjointed. So actual recommendation from that visit was to encourage all functions to complete or update their function-specific emergency risk management plans in coordination with the emergency management agency and each other to ensure function-compatible emergency prevention and response operations. So how do we get from that to a strategic plan? And that's a fantastic question. So thinking about that chain that Ashley had shown before in her presentation, going from IHR all the way through the joint external evaluation into some sort of national action plan, or in this case, a strategic plan. So we can use that information that you've seen here in these recommendations and these different observations, and we can turn that into a strategic goal. And in this case, the strategic goal would be standardize the public health emergency management program. So you can see that that is a pretty broad goal. And underneath that goal, we would have more specific objectives. So in this case, one of those objectives could be develop multi-sectorial, multi-hazard preparedness and response plans. Now, hopefully you see the direct link between those recommendations from an outside body to the country on some of the things that they need to achieve. So we know based on planning processes and lack of personnel and lack of attention on some programs that you're not going to do this most likely in a year. So when we figure out what do we do each year in order to obtain that objective, which then meets our overall goal. So in this case, in year one, this is where those performance measures come in. We establish a plan, multi-sectorial plan development committee. So this is the committee that will work together from different organizations to help develop this plan. And then we're going to train everybody on what is plan development and what process are we going to use in order to make sure that our plans are consistent and that they cross over all of these different sectors. We're going to conduct research on our current plans, policies, and legislation that will inform the process, because we have to know legally what are we both required to do as well as what we can do when it comes time for an emergency. Most countries have some sort of public health act that outlines these things, but there's also natural disaster acts or emergency management legislation that outlines responsibilities across the government for who does what and where. And then we'll say maybe in year two, we'll conduct this preparedness and response planning. So you can see how we process from the international health regulations through our JEE, through our results from the JEE, and us picking those recommendations and turning that into a strategic goal. What do we want to accomplish over time? And then our specific objectives as to what we and how we accomplish that goal. Year two outlined the execution of preparedness and response planning tasks. Operational plans in the US are based on capabilities-based planning efforts. You can go back into all the Homeland Security presidential directives and all the policy directives, NIMS and everything else, and you can see that there is a deliberate process that we're required to do in the US through capabilities-based planning. So that's understanding what capability we want to have and then developing these plans in order to execute that capability. But as you've seen lately, probably around the world, is this growing trend of situation-based planning or scenario-based planning. When COVID-19 kicked off, everybody was developing COVID-19 response plans. There was a big push by WHO in the last couple of years to do influenza preparedness and response plans. When Ebola happened in 2014, 2015, there was a big push on Ebola planning. So we've seen a lot of emphasis in the last few years on these scenario-based planning. Is that wrong? Not necessarily. Is it the only way to go? Not necessarily. It really depends on the country and where you can gain traction when you're developing a capacity development plan for a country. and looking at what they have and where they're going and where we can guide them to build more capacity on their behalf. And we can base our ongoing operational planning based on the strategic goals and objectives. So there's that link, the link from IHR to JEE to strategic plan now to operational planning. So we can outline, as we did here, year 2, conduct preparedness and response planning. That's our objective for our year 2. So in year 2, now we can start this planning process. And how do we do that? Well, often there are quite a few things that have input into that. Laws, regulations, policies. The former Soviet countries deal with the pre-cause system. You can find data and information from your threat and hazard identification risk analysis or your strategic risk, vulnerability mapping. If you're looking at disease-specific things, you can often look at that One Health disease prioritization, normal health statistics, relevant disaster info or data from your emergency management community. None of these things by themselves are the end-all be-all, but when you put all this together, as we'll talk about in a little bit, is how do we get, where do we start? And all of these things have input into each of these different areas. So following this logical process, strategic planning can be informed by your evaluation results. So looking at what do we currently have as a starting point for where do we want to go. These can really inform decisions about your goals and objectives, and then those goals and objectives can outline where you want to go with your operational planning priorities. So with that, I will thank you for your attention, and I will at this time turn the floor over to Dr. Julie Fisher, pending your questions if you have any. If you have any questions, please feel free to put them in the chat. If not, we'll have a little short question and answer period before we move on to the next section. Dr. Fisher.
Thank you. And again, I'd like to remind everyone, I'm sorry, I know I keep dropping it in the chat box, but I know that some of you have joined us a little later. I just want to remind everyone that if you do have questions throughout this pre-conference workshop, you are more than welcome to drop them into the chat box, and we will be monitoring and responding to those, or to raise either your real hand on camera or to raise your virtual hand, which you will find by going to the toolbar at the bottom of the Zoom window and clicking reactions, and you will see raise hand under that. So I'm just going to very, very briefly add a brief comment to what Jim has illustrated and give like one example of a country experience in using this approach. And this is an extraordinarily brief presentation just to talk about illustrating how this works. So this is a countrywide example. I'm not naming the specific country, but it is from an actual experience with national partners implemented through a partnership between a US government partner, a Ministry of Health partner in another country, and a group of non-governmental organizations, including nonprofit organizations and academic partners who helped participate in the process, which I'm going to provide a very brief overview. There was a lot of planning that went into this overall process. So when I show here that activities took place on days 1 through 4, this is the period of a workshop involving multiple people from different sectors in country Y. And this is to illustrate the process of going from scenarios to planning. In this specific process, we worked together collaboratively to determine the most realistic scenario for meeting a specific country objective, which was to test their national Rift Valley fever response plan, particularly in the context of a new national public health preparedness plan that had been recently developed in alignment with this JEE process that is being described. So what they were really interested in doing was to take a One Health approach and to call out, now that this new overarching National Public Health Preparedness and Emergency Response Plan had been developed, did the National Rift Valley Fever Response Plan, which is inherently multisectoral, it has to address human and animal health with input from environmental health sectors, did it still work? So we developed a realistic scenario over a period of weeks, working back and forth, first in person and then virtually, and developed a scenario in which an outbreak unfolded in a very realistic way, because we based it on an historical outbreak. And actually, because of that, we were able to use real data and share it with the participants as injects during this simulation exercise. We conducted this as a tabletop exercise for participants from human, animal, and environmental health. And they worked during the exercise in task forces, as described in the new National Preparedness Plan, that assigned experts from communicable disease and epidemiology groups within, again, each of the sectors, on the human health side, on the animal public health side, and on the environmental health side, to task forces to work on investigation and case detection, to work on response, to work on mobilizing resources, and then a command and control group representing the Public Health Emergency Management Corps that would be, they did not have a Public Health Emergency Operations Center at that time, but that would be representative of the work happening at the central level. So we unfolded this scenario over about a day and a half, providing participants with as realistic injects as we could. So the injects being an example of a report, for example, of human cases detected, of laboratory results, a report of identification of sick, of either ill people or of potentially infected animals targeted at these different working groups. We finished the scenario-based exercise, and then we immediately went into an after-action review on the next day. The after-action review was intended to review the outcomes, what worked, what didn't work, and to define specific corrective actions, which is, again, as Jim has talked about, part of the process of going through understanding how best to address the weaknesses that were exercised. But we wanted to make sure that we did not leave this process without very specifically focusing on identifying the gaps or barriers to full implementation of that national RVF contingency plan that we were testing, while everyone's memories were still fresh. And while we could go immediately from the places where there were challenges observed or gaps to say, is the plan itself enabling the actions that need to be taken? Is it enabling coordination and communication across sectors? Or is the plan inadequate or even in conflict with the new overarching national preparedness plan? So we identified those places. And then on day 4, we identified and recommended specific changes to that contingency plan and to the multi-hazard preparedness plan where needed. Where does it need to be changed to be actionable across sectors? When we developed our action plan then for concrete next steps, we included the assigning who would be responsible for making those revisions, who would be responsible for seeing that they were approved and implemented, and then who would be responsible for seeing that those changes were disseminated and shared with all of the key stakeholders. Again, not a plan on a shelf, but rolled out to the key stakeholders in human health and animal health and environmental health, so that we went from the process of the exercise and identifying gaps to correcting, to identifying where plans needed to be corrected and updated, and then having a firm action plan for how those changes would be implemented, how people would be made available, and how they would be rolled out with milestones and dates and responsible actors. so that we went from the immediate observation of roles and responsibilities and what mechanisms and resources are in place and where there were gaps and needs immediately to correcting, thinking about what the operational plans looked like and how we would implement them. So I just wanted to provide that one illustration and appreciate the opportunity to give a specific example. We have some time now for discussion and questions and answers. We are actually not a huge group. There's 40-ish people on this call. I would like to invite you to please come on camera if you would like to, and to take a few minutes here before we move on to the next part of the discussion to ask any questions, to share your own observations or comments, and to please, again, either through the chat or by raising your real or virtual hand to ask any questions. Oh, thanks, Steph. So there was a question in the chat. That's an awesome example. Did you find any follow-up from the planning, e.g. after they created their plan, did they test or practice again? That's a really good question. We identified that parts of the plan were severely dated because they were based on old structures. And we also identified that one of the challenges had been that the plan was created by people who were technical experts in their fields, but who were very academic. So the plans were incredibly informative. There were large parts of there was a lot of research in the plans. There was a lot of technical explanation. They were very rich with detail, but they were very short on operational guidance. So it spurred a dividing out of the plan and rewriting it so that the people who would actually be implementing it had some input into what that operational guidance would look like. So what guidance do people need at the regional level, at the provincial level, at the district level, to actually be able to do something with this guidance, not to just have a background. Yes, they drafted the plan, they revised it. The question of whether they were going to test or practice again, it would have happened in 2020, and I think it was disrupted by, unfortunately, as so many things were, by COVID. So I think there's definitely a need to follow up in that particular case and see if there's now an opportunity to follow through again. But it was part of the action plan initially, and I think had events not disrupted, there was a clear planning and timing for update the plan, propagate the plan, review and collect feedback, and then exercise the plan again, which is absolutely critical. Okay, any other questions right now?
Really, I'm
All
not
right.
seeing any.
Yeah,
Sorry.
yeah, no problem.
Not seeing any questions in the chat.
Great, thank you. Hello, welcome back, everyone. Okay, just flipping on my screen very quickly on the agenda. Where we are right now is we've just done our overview. After our brief break, we are going back to a presentation. Jim is going to present, he's going to introduce the planning prioritization process. We're going to talk about that and present a case study, and then we're going to have some breakout sessions to discuss key considerations. And then following the breakout sessions, we'll come back briefly to present the findings from our breakout groups before we have a wrap up and closing remarks. All right. Jim, do I have you back here?
You're muted, Jim. Jim, you're on mute.
I was just talking to myself. It's more fun that way. Okay, so let's talk about how do we do this practically? Practically, that's always a great question, is how do we do this practically? So practically, what we wanted to do was give you an example of what we did in the field in one country that supported this process and used pieces and parts of this to help this particular country in their strategic planning and the beginning of their operational planning. Because the most common question I get when I'm out in the field is serving as a technical advisor when we talk about planning is, where do we start? What's first? And that can be a daunting question, especially for a country or for a group that has never done this sort of thing before. So, as I said before in the previous presentation, domestic emergency management, or the processes that we use here in the United States, is filled with processes that outline how we do this. We have the National Incident Management System, we have the National Plan Development Process, we have all these planning courses, we have CPG 101 or Community Preparedness Guide 101. We have lots of things that tell us how to do this process. Where do we start? Well, internationally, we don't necessarily have that one thing that says, here's how you must. Instead, we have different organizations like WHO who lay out a process that can be used. For example, WHO published this a strategic framework for emergency preparedness back in 2017. And this framework outlines some of the core elements of preparedness at all levels of government. So thinking back to Ashley's presentation where she mentioned all these different levels of government, the local level, subnational, national, regional, global, all these different areas. One of those core elements in that framework is plans for emergency preparedness, response, and recovery. And in that section, it talks a little bit about what planning is and what types of plans that you're looking for. But once again, it goes back to the same question. Where do I start? How do I figure out what's the first step? So in my previous presentation, I talked about linking the joint external evaluation and the results or the recommendations from that into the strategic planning process, which then could outline our goals and objectives and our performance measures, our multi-year plan for how we're going to do it. And then as we progress through those years, that sets us up for starting our operational planning process. So how do we prioritize what do we want to plan for first? One such method contains two steps, which is one, gather all that necessary information, and two, review that information and data with all of the relevant stakeholders. Now, you may be asking yourself at this point, how do I know what to gather? Where do I get the stakeholders? Well, sometimes you can go back to, as we mentioned before, things like the Public Health Act, or if you have a emergency management agency or organization in your government, you can work with them to look at national plans or national legislation that outlines roles and responsibilities for different groups within the government. Sometimes, like with the Public Health Act, you may say that the Ministry of Health or the National Public Health Institute is responsible for quarantine during an infectious disease outbreak. Okay, so that document right there gives the Ministry of Health the authority to do quarantine. So how do I take that and turn that into a plan? Well, that's where we can go. We can get all of these stakeholders. If I think about quarantine, I think who all would need to be involved in quarantine operations during an outbreak. Okay, so where would we quarantine? What would we quarantine? Would we quarantine at land border crossings? Would we quarantine at the airport? Let's just pick the airport. If I were to set up a quarantine station at an airport to catch any potential cases arriving by air, who would need to be involved? And you can see where this is going. You can just follow this string and ask those questions about who we would want to be involved. Is that the total scientific method for how to do this? Not really. But once again, where do we start? It's how do we start this process? And sometimes when there is so much there, picking one thing and using that as your starting point can often inform the rest of the process. And that's where we get this information. Where do we get all this information? So here are just a few examples of where this could come from. If the country or your organization had done some sort of risk assessment, that is definitely good information to have. And let me step back for a second. The caveat for this entire presentation is an example of my role as a technical advisor or somebody who is providing capacity development services to a country. And since most of us on the call are either from a country that would have some sort of role in this, or those of us who also dabble in the academic community are often called as advisors or teaching this process, as well as a lot of us that have served as consultants or in other nonprofits, we're called to do this work. So looking at it from all these different angles, it could be useful for you to see what this process could be like, and then how could you take parts and pieces of this and use it in your own role. So as we stated in the previous presentation, previous joint external evaluations or other assessment results before the JEE, the International Health Regulations had a self-assessment checklist that could have been used. There are other assessments that are out there. If you're a country and you've been through the Global Health Security Agenda as a phase 1 or phase 2 country, more than likely you have done some sort of evaluation or assessment. And let's face it, the number one response when we are asked to build capacity in the country, the first things out of our mouth was, where's the assessment? What's been looked at? Where do we have input? So for a country, these results are great because they can provide a lot of information that was found by maybe some sort of subject matter expert or some sort of outside organization that gives you recommendations. And these recommendations can often be based on data or information that was gathered during this evaluation process. So you can see how these different evaluations and assessments can provide a lot of necessary information. One of the ones that we used in this particular country, which I was actually kind of happy about because I had never used this before, and it was something that was really very, very informative, which was this One Health Disease Prioritization Process. And this process outlined all the priority diseases through this group that was assembled. Now, in this case, or in the case that we're about to talk about, this assessment was a few years old, but it still listed quite a few different diseases and why they were prioritized. So that's another great source of information. Health statistics are another good source, and you may be thinking, okay, why would health statistics be a good source? Well, let's take non-communicable diseases, for example, high blood pressure. Why is high blood pressure important when you're planning for an emergency response? Well, if you have a population where there's a high density of people who suffer from high blood pressure, and if you're in a healthcare system in your country that provides all free medical care, how do you make sure that during the disaster or during the disaster response, that the affected population still has access to those necessary medications? So it's not something that would probably tell you, we're going to have a mass disaster because of high blood pressure. But in the same point, when you're planning for how you would respond to something, you have to think about stuff like that, especially if you're in a country that has universal health care. Disaster data is another great source. I tend to say what happened in the last 50 years, natural disaster wise, any types of large attacks, warfare, conflict, you name it, those can be great sources of what happened and what were the consequences of that. Any past emergency responses are another great source. We threw in the term interaction review on this one because through COVID, WHO came up with this process to examine what is happening during the response that would help inform what they need to do to continue, as well as what has happened after other responses. As Julie mentioned, another great source is simulation exercises. What did we learn from those exercises and what did we observe? And then how do we immediately funnel that into some sort of formalized corrective action program? And can we use that corrective action program as a central database for information and data that can inform our planning process? When we review this information with our relevant stakeholders, in order for them to be best prepared, it is better to see if you can provide that information before the meeting with the stakeholders. But if you cannot, having it all available there as we go through it in a review process is extremely important. And that just makes sure that everybody has the same information, that we're all starting in the same place. Once we have that meeting, then we can outline our process for what we're going to do to review that information. And then we conduct that review, looking at the data that we have, and then hopefully prioritizing that list of hazards that can be used for the planning process. So, and I'll just say right here also, as I go to a lot of different countries and I work with a lot of different governments and I work with a lot of different programs, there is no one right answer to what is the priority for that country or what should be a priority for a country. I was working in Southern Africa with a country, and their number one, actually number two, hazard that they've put on their hazard list was driving under the influence and car accidents. So car accidents were a huge health factor. And instead of concentrating, I thought, concentrating on natural disasters, they really wanted to put a lot of planning and effort, preparedness-wise, into prevention of car accidents. And I thought, okay, well, that's not what I would do, but that's their country. That's what they decided to do. So I helped them plan on that, which, like I said, was a little weird, but for me, but it really was very effective. And it also helped them look at some of your not so normal ideas during an emergency response. Like I said, about non-communicable diseases and other types of medicines and things like that. So if you're out there as a capacity developer or a technical advisor and you see something like this, just roll with it because it's important to them. And our job often in building capacity is to help them with a process that they can then adopt and use on their own. So if they're wanting to use this process for something like that, it's good that we have the opportunity to help them through that process. So in this case, we're going to say this is country X. This was a country in Central Asia. And I was tasked with doing a workshop on how to determine priorities for planning. So we came up with the title P3, which is Planning Prioritization Process. And we developed this workshop to take kind of the all-star hits of all of these different sources of information and roll it into a process very similar to what we talked about in the previous presentation, and how do we take some of these sources of information and turn that into a planning process? So we were asked to provide assistance on a more deliberate planning process. This country had a process, but it was led by others. And health and public health was very much ignored in this process. So the health authorities, the health system, the National Public Health Institute there asked for our assistance to put this together. So as part of that information gathering process, it was determined that they did not have a dedicated process themselves for developing plans. They participated, they lent their input, but as far as internally to the Ministry of Health, they did not have their own process. And as is the case in a lot of places, they didn't know where to start. Where do we get moving on this? It was, we know it needs to happen. We know there's a lot involved, but we just don't need to. We don't know where to start. So we developed a workshop to help them develop the planning capacity within their staff and the organization itself. So as part of this workshop, we led this multi-sectoral country representatives through this process of looking at information and data that was relevant to the country. And once again, this is the question I get is, who do we invite to this? And often we just sit down and we start to look at, very basically, who would we want to involve? And then we can work through that list. Now, sometimes you may get it right the first time. Often we don't, because if we don't have some sort of legislation or policy or existing plans that outline roles and responsibilities, we're just really looking at it from a practical perspective of what people have done in the past, and then how do we use that to inform where we are going forward. This was the agenda for the workshop. They put a lot of emphasis on this disease prioritization process they had. And so we knew that was going to be important. And we also knew that this process was years old. So we wanted to make sure that we had a way to validate that information. We had the threat and hazard identification process, which we'll cover, stakeholder analysis. Then we gave them a process by which they could use to develop plans. And then we started a plan. So we took them from validating and discussing what they had all the way to the beginning and writing of some of these plans. So this country had completed a One Health disease prioritization workshop back in 2018. As part of that process, they developed a list of 32 priority disease threats. Now, in theory, we would have loved to have all the participants from that first workshop involved in this workshop. But as you can imagine, with turnover, coming out of COVID, all the different priorities on the health system at the time that we did this workshop last year, they couldn't pull that off. We did get some that participated in that workshop, which was great, but we had a lot of new faces. So out of those 32 priority diseases, we were asked to review them as part of this workshop to determine whether or not they were still valid and whether or not they were still priorities. So the workshop facilitators reviewed the One Health 5-step prioritization process, which if you go to cdc.gov and look at the One Health page, you can find that process there. And that process has 5 steps. The step 1, prepare that group for their work. Step 2, developing that criteria. Step 3, develops the questions. Step 4, ranks the criteria. And step 5, ranks the zoonoses. I'm not going to go into real detail in each of these steps. Like I said, if you're interested in that process, it is on the CDC website. But what we did is, as facilitator, we walked them through each of these steps. So we recapped what that step was. We then presented what the results were from each of those steps as part of the workshop that was held in 2018. And then we broke the workshop attendees down into small groups and asked them to review the results of each of those steps, validating whether it was still correct, and then reporting their findings to the large group. And as that process played out over this day, so normally this disease prioritization piece from the One Health side is a multi-day workshop in itself. But since we were only validating the list, we just looked at some of the pieces and parts of it and validated the things that we thought was necessary. The end process of this was a list of that same 32 priority diseases, and there were only, I think, maybe 1 or 2 changes. And it wasn't a change as in drop this one, add this one. It was a change as in, okay, this one was number 13. This was number 14, let's switch them. So in the end, all 32 that were on that list stayed on that list. The top, like I said, I think it was like the top 13 or 14 stayed the same. So when it came time to include this information later on, we had a validated list of 32 priority diseases in this country that we needed to consider when it came to planning priorities. So the next step of that process was, now that we have these priority diseases, what else do we need to look at for determining what our priorities are for planning? This country had also previously participated in a WHO-led strategic tool for assessing risk, or STAR workshop. Some of you who are familiar with US-based doctrine might be familiar with the THIRA, or the Threat Hazard Identification Risk Analysis process. There are other tools out there like VRAM, which I believe is a WHO AFRO tool, but there's a lot of different tools out there that outline what are the strategic risks that we face, or a country faces, when it comes to risks. So in this process, they had identified numerous potential threats and risks that are associated with them. Some of those that you may think of: flooding, large weather events. This particular country had a history of earthquakes. One earthquake back in the mid 20th century destroyed 3/4 of the capital city. So this country is faced with a history of earthquakes going back quite a few years. And they had quite a few other little threats and hazards that they faced. This country also has a large transportation corridor. So there's a lot of goods and services that are passed through this country. So they ship a lot of things. So shipping disasters or accidents were something else that were high on the list. So in order to look at that process, which the STAR results were pretty dated, they asked that we would once again validate the STAR and the STAR results. So we did an abbreviated version of the THIRA, which we called the Threat and Hazard Identification Process. So we didn't go into a lot of the deep risk associated with these, but we did go more into what is the consequence or context of what would happen if these particular threats and hazards came about. So the process consisted of 3 steps. One was to look at history and develop these lists of threats and hazards. The second was to determine the context of those hazards, such as if it happened during the day versus at night, if it happened in the winter time versus it happening in the summertime, if it happened in the large city or small city, if it happened near the border or happened in the central part of the country. So these contexts are important when determining which of these threats and hazards are important. One thing that I didn't really go into in this presentation, but we did talk about, was geographical context and understanding if something were to happen in a different part of the country, would it be important? Would it be more threatening than it would be in another part of the country? So an earthquake in the capital city versus an earthquake out in the countryside there are different consequences of the same earthquake, just in different areas. So geographical context is also something that is extremely important. And then developing that priority list. So which of them would be more devastating, which of them would affect more people, and you kind of set that criteria for how you would judge these different threats and hazards as to which ones would be most important or a priority when it comes to planning. Now, take another step back for a minute, and as we go through this process, first the diseases and now the threats and hazards, one thing that you also need to compare this to is anything that's existing plan-wise in the country. And I know we said we would do our research, but we can also eliminate some of these threats and hazards if there's already a plan in place, or if there's a reference to this somewhere else, and then we can draw that inference back to that particular plan and maybe just expand on it versus having to follow the whole process and write a new plan. So we worked through this process, teaching them the process, and then we had them break down into their groups again, and we gave them practical exercises designed to not only help them learn the process and apply it, but they were also instructed to use their real information and data from their country. So at the end of this session, they had a prioritized list of the top 3. Now, they obviously went through more and developed a longer list than the top 3, but for our purposes for the workshop, we just wanted to concentrate on those top 3. So we have this prioritized list of diseases, and now we have this prioritized list of threats and hazards. We can start to put that together and figure out who do we need to have involved. So the Ministry of Health or the National Public Health Institute or whatever body is doing this or leading this planning process, as we've said before, cannot do this alone. There are many things that affect a response to some sort of disaster or some sort of disease outbreak. I mean, think no further back than the last 2 years. It shows in the last 2 years that our process with COVID and responding to COVID, it's not just the health authorities that are responding to something like this, it's the bigger community. So we then led them through a process during this workshop of who do we want involved or who needs to be involved. So we looked at all of those. They had formal and informal agreements to support the development of plans, policies, and procedures, but they didn't have a list of all the specific stakeholders based on each of these different types of scenarios. The facilitators walked through the process of stakeholder analysis with the participants, and we looked at 6 different steps. Identifying and listing key stakeholders based on the identified priorities and threats and hazards, created a contact list of relevant stakeholders collated to those different priorities and threats and hazards, determine their functions, roles, and responsibilities of each of them. We identified and match stakeholders with similar skills, and then identify critical elements needed for data management, establish and maintain a database of those stakeholders. And then as we work through this process, we give them time to do that. So you can imagine this is day 3. We had a busy day on day 1, day 2, and day 3. This is where we decided that instead of trying to cover all 3, let's say 3 of the top diseases and 3 of the top hazards, the group was polled to find out which 3 things that they would like to concentrate on. So out of that group, they chose CCHF, flooding, and anthrax as their top 3 disease priorities and hazards, or disease priority threats and hazards that they wanted to continue this process with. So then we broke them down once again into groups, but this time each group was given a top priority. So from this point on, that the rest of the workshop, these groups concentrated on that one particular priority. So when we went through the stakeholder analysis piece, they were concentrating strictly on their priority. Once that was done, we brought the groups back together at the end of the day, and they reported on who their stakeholders were and what types of support that they could provide in each different scenario. Which led us into the next portion, which was our plan development process. This country had some plans. It had a lot of plans, actually, but the problem was they were not consistent. They were not in the same format. They did not follow the same process. And as you know, when you get into some countries that rely heavily on foreign aid and foreign assistance, the plans are often shaped by the person providing that technical assistance. So the plans that they did have, they just didn't look the same, nor were they containing the same information. There was just no consistency. So part of this process, we were asked to provide a process by which they could use to develop their own ability to develop their plans. So they were looking at the plans that they already had, as well as the plans that they wanted to build. So in this case, we used this process, as I describe here, the process for developing plans. Now, those of you who are experts in domestic doctrine for emergency management may recognize this process. This is actually the National Plan Development Process from a few years ago, before its last update, that we have adopted to use internationally. Now, do we use every step of this process and lay it out the same way? No. But there are some really good things there that we can use that help us organize the planning process overseas, especially where a lot of places I've worked. So step one, form that team. Who are we going to have on this team? That goes back to our stakeholder analysis. That's how and why we do that, is in order to inform who our planning team is. Step two, understand the situation. So how do we understand the situation? What's going on? This is where things like our disease prioritization, the threat hazard identification process, the strategic tool for assessing risk, the JEE, all these different assessments and reports and processes and tools that we use help us inform what's going on. This is also a great place to insert your language from different laws, regulations, policies, procedures that are in the country that outline what is to be done and who's to do it. The next is determining our goals and objectives. What do we want to accomplish in this planning process? Now, this is not to be confused with the goals and objectives in the strategic plan. These are goals and objectives for what we want to accomplish in the planning process. So are we looking at developing a large multi-hazard, all-hazard response plan? Or are we looking at developing scenario-specific plans? You know, what are we trying to do with this planning process? Number four is the steps to actually develop the plan. That goes into things like courses of action and actual determining how we would do something, which goes into step five, and how do we actually prepare this plan, pass it through different series of reviews, and then obtain approval for the plan itself. That last word, approval, can be a long process. Sometimes that approval process can outlast your technical assistance project. You know, a year or 2 years, depending on the process where a plan has to be approved and who needs to have input and approval on it. It could be a long process. So, just sometimes be aware from a capacity developer standpoint, you may start something and you may not get to see the end of it, but just know, hopefully, as you build this capacity, that they take it upon themselves to finish this process. So what we did was we used one example, which was an emergency operations plan. Now, we can go all day about what the right plan is. We can look at 1,000 different source documents that say you must have this plan, you should have that plan, you could have this plan. This plan here is mentioned in the WHO's framework for developing a public health emergency operations center. And a lot of the work that I do kind of centers around integrating the EOC with public health programs, or integrating those public health programs into the EOC. So a lot of times I'm asked to support the development of some sort of emergency operations plan focused on the EOC. So in this particular case, in this country, that is exactly what I was doing, was how do I integrate all of these different programs, traditional public health programs, into the EOC or into this emergency operations framework. So this template consisted of these different areas that you see here on the slide. One area that I often get asked about a lot is the second bullet there, record of changes. And this is just one of those things that you see from domestic doctrine for Plan CPG 101, CPG 102, 201, all these different areas that outline how to work in an emergency. The thought is, how do we track changes to this plan? Does it require us to change the entire plan and get it reapproved, or are there different areas that we can update that don't require us to have another approval process? Or are there things that we can pull out of the main plan and put it in an appendix or an annex that we know can change and will change, but yet doesn't require us to approve the entire plan itself? So for this particular workshop, we chose to concentrate on two things. One was the introduction or the situation, the why, and then the mission, the objectives, and the strategies. So what we intend to accomplish, what are we or how are we going to measure that accomplishment, and what are the strategies we're going to use to accomplish the mission. So at this workshop, we went through the entire process, explained each and every one of these, had small little practical exercises that worked the participants through writing examples for each of these. And then we broke them down into their groups again. There are 3 scenario-specific groups, and we asked them to write the situation, mission, objectives, and strategies for their priority. So either CCHF, flooding, or anthrax. And once that was done, they were able to brief the large group on what they did. Now, you can imagine this is a lot to accomplish in 1 week. So what we tried to do was to make sure that we didn't overburden them with instruction, but we gave them more opportunity to do hands-on work. Some of the things that we covered in this workshop were recaps of training sessions that I had previously with them. So some of the ideals, like what is an EOC, what's an incident management system, what is a plan, what is an SOP, these weren't new concepts, because all of these participants in the workshop had been through some sort of training up to that point. So we didn't have to spend a lot of time going over those again. But, some of the lessons learned from this workshop, as a result of the workshop, they were able to answer that question for themselves. Where do we start and how do we do it? So we transformed their process of you tell me to let me tell you where we're going to start. And when we're building capacity and we're trying to build sustainable programs, that is music to my ears. When somebody says, oh no, I know where we can do it and I know exactly how we do it. That right there, regardless if you walk out of there with a signed piece of paper for an SOP or a plan, giving them the ability to do it themselves over time, to me, is more important than walking out with a signed plan. So that was something I felt like was a big success. Participants validated their list of priorities, which was another success. Giving them a process that they could use to review and develop these lists was another big win in my book. They walked through that process both with a example and with practical information. So they applied their country specific information to the process. So not only were they learning something new, but they were able to use what they already had and their knowledge and put that together. So it became more personal for them. So they became more invested in the process when they're using their own information for what they were trying to do. Now, obviously, there are a few things that I would do differently, or things that I learned while I was there. And the first one there, preparation is key. I mean, we all know that. We know that the more you prepare for something like this, the better it's going to go. The participants for this workshop were given months of encouragement and direction and recommendation for how to prepare, what to gather, what kind of information do they need, how updated did it need to be, who are the right people that needed to be involved. And while they did do some preparation, they did not do enough. So we found ourselves kind of wasting some time going through where to get things when they had already been told and guided where to get those things. So once again, it's follow up and follow through are two things that you have to constantly do, especially when you are not there in person. Often as capacity developers, we are there for a week to 2 weeks, and then we go home or maybe go to another country and work on another project while we expect them to continue the work. But when you're not there every day to help guide them, other things take priority. So it's understandable. It's just sometimes disappointing. Having the right people there is paramount. While we felt like the right agencies and organizations were there, the problem is they didn't send people who could make decisions, and they didn't send people with the requisite knowledge that we were looking for. So sometimes, a lot of times, as somebody who's organizing this, that's out of our control, and we work with what we have, but it is what it is. We just need to try to make sure that the right people are there. And as always, you are only as good as the information you are given. When I do this, I have a 5-step process for capacity development that I use. And as I joked about before, the first step is assess. Then I develop a strategy. So assessing to me is asking questions. What do you already have? When was it done? What is it? You can imagine all the questions that we ask. And we feel like sometimes we ask the right questions, but sometimes we don't. In this particular case with this country, it wasn't until 6 months later that I found I asked the wrong question. And it would have saved a lot of heartache between the time we did this workshop and the time that I was there next with them to do some one-on-one assistance. We were given some information that while we were there that really just changed our perspective on what we were doing. But we didn't ask the right question. So it's hard to ensure that you're asking the right questions while you're there. But sometimes it just sneaks up on you. So just don't get too frustrated, I guess is what I'm trying to say. If you're new to this process, or even if you're a veteran of this process, sometimes you can kick yourself in the rear end if you miss something. But adapt and overcome. And the last but not least, follow up. As we said, you can't be there every day. So trying to make sure that you encourage them still is what's important. And it's one thing to provide a workshop to quote unquote build capacity, but it's another thing to actually build capacity. So we go in with these workshops and we do our monitoring and evaluation plans and as implementers or as academics, and we say, we're building capacity if we have this workshop for 30 people. So we had 35 of that people. Did we build capacity? I would beg to differ and say, is the number of people that sat in a chair actually building capacity, or is it what did they do with that information when they left, and how did they use it? Is that building capacity? So behavior is not changed only on instruction. Behavior is changed based on constant application of the instruction and the processes that we teach them or we give them, and then constant follow-up and encouragement, and letting them lead some of these efforts so that it becomes personal and they adopt it in a way that now they can apply it over time. That's, in my opinion, building capacity. So 45 minutes on the dot. I just wanted to share with you how I use this information and how I use these processes and how I help through capacity development efforts with other countries and other organizations to apply this information for their gain and their use. So with that, Dr. Fisher, I will pass it back to you, and we can talk a little bit, I guess, about what's next.
Thank you so much. So there are a couple of questions here to address, and I think it's Jim, if you have a minute to address questions, we can, and then I think the next thing is to go into our breakout groups. So the questions, and I'm going to go from most recent backwards. Steph from GW said that she finds that pointed out that sometimes participants are not very interested in a discussion or tabletop, but then when real life happens, there's panic. So any tips for helping reinforce the message of the importance of practice?
That's a fantastic question. And you often don't have the ability to force them into applying what you're teaching. But I think that's where that follow up and follow through comes in. If you are on a project that allows you to have multiple engagements over time, that often helps. But you're right. I mean, a lot of times we go in and we teach this, my favorite process is to teach people how to develop an SOP through actually walking through the processes. So my number one thing with an SOP in the EOC is who unlocks the door, and getting them to actually act it out and think through things helps to bring interest into it. But yeah, you're right. If they're not interested, which often happens, there's not much you can do except for continue to follow up and follow through. And you don't want to seem like a nag to them, but sometimes that push, that gentle push, is what is needed after the workshop in order for them to adopt those different processes.
Okay, Jim, there's a couple more questions. Susan had asked earlier in the session. I know you talked about the variety of tools, but her question was about specifically what tool you use for threats and hazards identification process. I know you touched on it, but if you could just describe it briefly. And then she also asked that in this pandemic, European countries were devastated despite most having strong healthcare systems and having already had SARS and MERS-CoV in the past. And she asked, what part of the healthcare strategic planning really needs to be addressed for future improvement? I know that's a very general question, but if you could just think about like some, maybe highlight a couple of the issues that are frequent gaps or needs.
Yeah, so the first question is, I use a variety of them. I don't rely upon just one. I think there are some great things in WHO's STAR tool that outlines strategy, but I also think that the threat hazard identification risk analysis process from FEMA is a good one. The problem there is it gets way too in the weeds sometimes. So I believe that there is a medium that I use, which is as was in the slide, the threat hazard identification process, which is an abbreviated THIRA, but also incorporating some of the strategic ideals from the STAR, I think are two good things to look at. As far as hospitals go, there, in my opinion, there has been a lack of attention on preparing hospitals for large emergencies. Yes, there are some programs that are out there that are meant to focus on that. But I think, and this is something that I learned kind of the hard way when I was a consultant for WHO after I had retired from the CDC, was we don't, in the public health world, consider the health system as a whole enough to make sure that we're including them in certain planning processes. So we often kind of let the hospitals take care of themselves. And I think that I think that showed during a lot of these responses where you had a big disconnect between the health system or the hospital systems and the public health system when it came to responding. So when we draw them together through that stakeholder analysis process and identify them as one of the key partners, bringing them into the fold when it comes to planning and preparedness and exercises and evaluations will help bring them in for the next one. And preparedness is a huge piece. As Dr. Fisher mentioned earlier when she talked about preparedness for laboratories, that's not something that you normally see. So when we start thinking about applying preparedness across the spectrum, we have to look at more than just your traditional public health programs, the EOCs, emergency management, things like that. We have to look at bringing in all of these other traditional programs into the preparedness world.
Yeah, thank you so much, Jim. And I just to make a very brief comment in response to what you just said, Jim. Again, I'm a huge fan of preparedness planning and exercises for laboratory settings, which is something that you don't really see that often. But coming back to the point Steph made that people aren't interested in a discussion or a tabletop, but then when real life happens, there's panic. Sometimes that exercise, if you can get people to the table, it is a powerful tool to show them where they do not actually have a strong sense of what they're going to do if there's an event. So for the laboratory, for example, in some cases just drilling, what do you do if someone walks into the door of the healthcare facility or up to the lab who has symptoms and signs of a high priority communicable disease? And they've walked through the door. What do you do next? We've done drills in countries when someone shows up with signs and symptoms of Ebola during the Ebola outbreak in West Africa, just to practice. What do you do when someone shows up at the door to get a specimen collected into the right point while taking all the precautions you're supposed to do? Because it's a low risk setting to fail, but it also really shows people what they are and aren't prepared for. We've also drilled, we do a lot of drills with like someone faints in your high containment laboratory behind the glass door. What do you do? Just going through the drill in real life or going through the exercise in a simulation is often really good at getting people's attention. If you can get them to the table and they can see what they are prepared and aren't prepared for, I think that's very galvanizing and helpful in and of itself in getting attention and support. Okay, any last comments, Jim? Anything anybody else wants to add, Louise, Ashley, before we go into breakouts?
Nothing else from my end, thanks.
Okay, perfect.
Okay.
Thank you all.
All right. I am going to thank you so much, Jim. I'm going to flip up on my screen what we are doing next. So the next thing we're going to do is we are going to be discussing with each other. So in just a few minutes, I am going to send you all into breakout groups. During these breakout groups, each group is going to consider one question and focus on discussing the specific question and then coming back and sharing it with the full group. So everyone will have a chance to talk about all of the questions, but in your breakout groups, you will focus on one of the following. If you are in group 1 with Luis and Ashley, you will talk about the common challenges faced in incorporating planning into health programs. If you are in group 2 with Jim, we're going to talk about the sources of information that you have used or that you would use to inform your planning process. And if you're in group 3 with me, we're going to talk about the resources that are needed to implement this process that Jim has described for the best potential outcomes. So again, your facilitators will have the questions. This is a chance for us to chat. It's only going to be about 20 minutes. We're not going to spend a lot of time in the breakout groups because we want to make sure we have time to come back into the full group to discuss more fully. The one thing I would like to ask is when you go into your breakout groups to please work with your facilitators to elect a chairperson or rapporteur who will report out to the full group at the end. All right, does that make sense to everyone? All right, in just a minute, you're going to find yourself assigned to a breakout group. When Zoom asks you if you wish to accept the breakout room, you need to say yes. Okay, so you will see, whoops. You will see in just one moment, once I overcome my technical difficulties, a breakout room request appear, and you will be able to join. Okay, great. Okay, everyone, welcome back. I think we are now a small but hearty group. I had no idea breakout sessions had such a dissuasive effect on people. I do think, though, that we had a really interesting discussion, even though our group is small. And as people are, I think we may have everyone back now who is still on. I think it would be great to just review some of the discussion and have in our small group any last thoughts and discussion amongst ourselves once we talk about ideas and responses to the breakout questions. Luis and Ashley, I think everybody is being pulled back into the main room. Do you have a rapporteur who's going to give your results, or are you going to speak to the responses?
Sorry, I didn't hear you, Julie. Can you repeat that?
Yep. So I think we're going to go ahead and start with you on reporting out from group 1. Do you have a rapporteur, or is one of you going to be the
I am
presenter?
going to be the one representing the team. Yes.
Okay.
So it was very interesting the discussion that we had, because both the participants that we had, or 2 out of the 3 participants that we had, were from Haiti or are from Haiti. So I think that the most challenging thing when it comes to planning and in emergency preparedness and response related topics in Haiti is budget and resources. So because when you make a plan, you need to either allocate or identify the different resources and budget to be able to implement that plan. That's when it becomes very challenging for the Haitians, because everything has to be approved by the parliament. And of course, budget always comes as first step, or what comes first, right? The chicken or the egg, or the egg. So it basically, that's the most challenging thing that they have in country. They are very willing to plan, but at the same time, they feel like they have their hands tied because they don't have the budget. And because they don't have the budget, the parliament is very hesitant in approving planning or approving any type of document that involves any type of resource of budget. That's what the discussion was in group 1, referring to question number 1, that what were the most common challenges when it comes to planning in country. I don't know, anything else that you might want to add, Ashley?
No, I think just a big emphasis on that I think would be interesting to talk about if we had endless hours is about the planning at the community level and how that intersects subnationally and nationally when we're building out strategic and operational plans. And I think more and more for COVID-19, where most countries found that they did not have enough trained surge staff, that tapping into the community could be a potential place for looking for more surge workforce and how we can do that. So I thought that was kind of an interesting discussion that I think we could spend a whole day talking about if we have the time. And back to you.
Thank you so much. Jim, do you want to jump in for group 2, and then we'll open the floor to discussion of all the issues that Ashley and Luis just raised from their group?
So for my group, the question was, what sources of information have you used or would you use to inform the planning process? And before we got into the question, we talked a little bit about golly, I'm drawing a huge blank, and I didn't write it down, so I'm losing it. Anyway, so it comes from talking too much. The one document that we did talk about a lot was the IAR as a source of information. And we drew the inference from the joint external evaluation, which we were both talked about again about version control and understanding the questions in one version don't necessarily match the questions in the next version, which then can throw off what was asked and what's recommended. So ensuring that you're looking at the right version and the right question. But the IAR process is very informative also when it comes to recommendations. And just as we drew the line from the recommendations from the JEE, you could do so with the recommendations from the interaction review also. So that could be another great source. Another was a thought was brought up on quality of data. Just because there's data there doesn't mean that it's quality or that it is useful. And we had a really good conversation about cholera versus COVID and what numbers mean in cholera cases and death versus numbers of COVID cases and deaths and the effect and planning priority and things like that. So it was a very, very good point about what are we comparing and how are we comparing things when it comes to the data in order to make a better informed decision.
Really interesting. Thank you. I'll speak out for my group. We talked about what resources are needed for productive planning. And I think we're starting to hear similar reports from multiple groups, because one of the things we did raise was, the question obviously of having time and budget is key, but we focused on a couple of issues about who's at the table and empowerment. One of the issues that was raised, particularly in preparedness planning for the facility level, is being given the responsibility for conducting planning for testing plans with exercises and following up, but not having any specifically designated authority to be able to follow up on the recommendations. And that was raised as something that needs to be considered from the beginning, so that there's a consideration if you're going to support the planning process, making sure that you have empowered someone to follow through with the recommendations and to be able to follow up. And I'll invite all the members of my group to also add to anything I've missed there. The second issue was bringing stakeholders to the table. And that's the support from higher levels to make sure that stakeholders are both free to and encouraged to come to the planning table, meaning you actually have to make sure that it can be, that they have the resources and the permissions needed to make that part of, to engage, because we are all overstretched. And then the third thing was really, in terms of resources, being able to engage key stakeholders from all affected communities in planning. So that means taking into account everything from gender representation when you're talking about preparedness planning at the community level, to including members of affected communities, including people, for example, one of the examples that was raised was for response, including members of the disability community, to identify what is likely to be an issue with access and to help thinking through both the development of plans and thinking through how to exercise those plans effectively so that they can actually provide contextual, accurate information about what the challenges are and what the resources are on the ground. So not assuming about what is making sure that members of affected communities are at the planning table and not assuming the conditions that they're facing. Anybody else want to add to that from our group?
Actually, you said something that sparked my remembrance. One of the questions that was asked was one of the bigger challenges when we are going into or helping a country often is that health and health systems and public health is not taken as seriously as it should be when it comes to being involved in the planning process, depending on the type of country, the type of government, the strength of the Ministry of Emergency Situations or National Disaster Management Authority, and what role that they're relegated to in current plans, as well as legislatively. Where do they stand with authorities in their Public Health Act or other places? So how do we overcome that when health is not necessarily considered one of the main priorities for planning when it comes to emergencies?
And I think at this point, thank you, Jim, for adding that. And I think that's a great transition to say, at this point, we're a small but hearty group. And I would love to hear any thoughts that you have on what's just been shared, what you discussed in your breakout, or any questions or discussion about what you heard today. This is a chance to ask questions, to share your own observations from past experiences, and to compare what has worked in specific settings from person to person. So please, really love to hear now from you if you have any specifically to ask you. From what you've heard today, is there anything that you have observed in the past as something that can be very effective in planning, or something that's really challenging to do with planning?
Well, a challenge that keeps coming up to me again and again is when we look at public health officials, and I don't mean to be just narrow-sighted in thinking in the United States, because that's where I am, so that's where my focus is. But I can see it in other reports from other countries as well, that scientists, public health officials, doctors, hospital workers are not respected for being knowledgeable anymore. Everybody would rather take misinformation, make their own decision, look online, ask a friend, rather than trust what's being said from, like the CDC or the World Health Organization.
So
public health has really been stripped of any kind of credibility in many areas, and it just makes it very hard for any of these plans to actually be implemented, because nobody wants to do what they're being asked to do, even if it's a simple thing like wearing a mask.
Well, and it also, to me, there are quite a few things with that, but as you said, the availability of information now online, some people just don't want to hear that there's a process that needs to be gone through in order to get the information right. in order to make informed decisions. So they feel like they can just pop on the internet and ask a question and they get an answer in 7 seconds from Google. And they look at a few websites and now they've become the expert. And what do I need an expert to tell me? I can figure it out on my own. And then when the experts stand up and say, hey, you know, this is going to take us a minute to make sure that we get this right, now they've lost credibility because why am I going to wait for you when I can go figure it out myself? You know, Uncle Joey's going to rub some boysenberry stuff on it. It's going to be okay. You know, but they don't understand that process, and they don't understand what we go through in order to come to that decision. And that's where I say sometimes it does come back on us a little bit when it comes to our messaging of how we portray that process to let them know. And so I, you know, obviously it's not our, I don't think it's our fault that they feel that way about us, but I still think we can do sometimes a better job of explaining that to them in a way that they will understand where and how we got to where we're getting. Just Jim's personal opinion.
Well, for me, I think there's the information that is available out there, social media, talking about the internet. Now everybody can access any material from anywhere in the world and the like. I think it's deep rooted. Even before the internet, even there were people who had a deep mistrust of government and public health. And we're just seeing the repercussions of the availability of social media and how fast people can communicate. For example, looking at vaccine hesitancy in my country, Nigeria, there, as a public health physician, I've been asked a lot of questions. Do you think it's safe? Why should you have the vaccine? And I know people who haven't taken the vaccine because they believe in the conspiracy theories. So I think something similar to what Jim said. I think we have to have a way of crafting messages. One thing that the Nigeria CDC did at the height of the epidemic, trying to get people to take the vaccine, is that they also had a hotline that you can call and ask questions. They also started sending messages on social media about what is known about COVID-19 at that time. So I think public health also has to rethink strategies in view of what is happening now. Thank you.
Yeah, I think that's a really, again, a really good point about what is changing moving forward as we're talking about community engagement, when this issue of trust, of bypassing expertise in favor of easily accessible information, it's something we're all facing. And I don't think it's anything we're very prepared for, quite honestly. Anyone have any experiences in different country settings or in different community level settings of trying to dealing with this question of engaging community in planning when there is this atmosphere of widespread belief and expertise? I was joking with a friend the other day that I used to have to explain what I did for a living, but I don't have to explain it anymore because now everyone's an epidemiologist. So I'd love to hear if there's anything that you found that has been really effective. No, nothing has been very effective. Laura?
It's a micro example because some of the people that I particularly work with are young women. And after the initial lockdown, we had a surge in pregnancies, and they were very hesitant to be vaccinated because of the lack of data on safety with pregnancy. So, you know, as we got more data, then it was a little bit easier. But as I mentioned before, I'm a nurse, so I have a healthcare background. And one thing that I was able to mention to them was all the frontline healthcare workers, some of them were pregnant and they were all vaccinated first. So we're going to have data ready for you, really available. So they're heroes in more than one way. Soon as we get it, you know, I'll show you the data. And that did help most of them. And then just having someone to actually talk through it, to just explain to them the risk versus benefit principle, that, you know, your risks with getting COVID are this while you're pregnant. Your risks of getting the vaccine, so far what we know from the data that we have, is this, and then helping them to, you know, make that informed choice. And a lot of them, what we did too is I just would say to them too, now this is what I know, put it down on paper, now go see your obstetrician, get information from them, to get a you know, a variety of information from different people that they trusted. And I think, you know, out of probably about 10 women, as I said, it was micro, 10 women that became pregnant during the pandemic, I think only one didn't get the vaccination out of them. So I considered it a success.
Yeah, thank you so much for that example. Nancy?
Yes, I'm from Haiti, and you know, it's so different. So we don't have many people that died from COVID-19, although we are putting in place a lot of program toward COVID-19 vaccination. So, you know, so it's like they don't trust us. It's like, why should we get vaccinated if there are not that many cases as compared to other countries? So why should we do whatever other countries are doing? Can we just, you know, keep it to, you know, the basic? Some say wear masks or wash your hands, but for the vaccine itself, there's a lot of hesitancy. But the worst part of it, it's coming from the healthcare workers themselves, lack of trust in the government, because they are saying with so many things happening, why should the focus be on COVID-19 vaccination? So those are the things that, you know, we're dealing, and those are really challenging. So even, I mean, we're putting in place the COVID-19 program. For the last probably 6 months, we were only able to vaccinate 600 and a few people. Although we're not working we were doing it at the community level, not at the site level. But it's so hard, you know, even there's a lot of awareness session, you know, engaging community, different communication a plan in place, but there's that hesitancy still there, and coming from healthcare providers.
Thank you. Thank you for sharing that. Turning back to you, Nancy, to the whole group. I mean, coming back to what we're working on here today, which is thinking about tools for turning some of these assessments and understandings, best practices, IARs, what we're learning from our experiences now during the COVID-19 pandemic, turning assessments into plans that can be that are operational, turning them into strategic plans, turning them into operational plans. From what you're both observing, which is, you know, again, different sides of the same experience. What are we learning about taking this experience and moving forward to make plans that we can actually use to prepare ourselves more effectively for the next crisis, whatever the next crisis is, because we do know that there will be a next crisis, whether it's an outbreak or a disaster, there will be a next crisis. And it will come in this environment in which there is lack of trust in public health, lack of trust in information. What have we learned that we can carry forward into more effective planning? I would love to hear anyone's thoughts. Silvana, did you want to add to that? No.
Well, you know, there has to be some way to build a value in people that offer the services. Like right now, there's just such a crisis in keeping healthcare workers employed. So, I mean, that would be the thing that I would really like to focus on, because it used to be nurses in the United States were the most trusted profession. And I believe we still are, but, you know, there have been at least 25% that have left employ since the beginning of the pandemic until now. And a majority of them are, you know, men and women of my age, which are the senior nurses that are supposed to be there as the mentors for the new nurses coming in. And this is one thing I feel that I am an expert on, is that a nurse does not become a nurse straight out of college. You don't know what you're doing when you hit the floor, and you need to have those people there that are veterans and can teach you. And I remember I learned the most about being an actual nurse in my first 2 years in the ICU. And, you know, just if we don't have that resource, then they're not going to be prepared for really any kind of crisis in a hospital or health setting.
Okay, so I think, you know, this is the challenge where we're all facing. We're in year 2+. We're talking about preparing for the next event while still dealing with the response to the ongoing COVID-19 pandemic. We're observing challenges in planning while we're trying to think about how I think, reflecting on a lot of what I've heard now, it's very difficult right now to get support from community leaders for coming to the planning table again when they're burned out, when there's lack of trust, when it's difficult to inspire people to think about the next event because they're still reeling a bit from this one. We have 5 minutes left. Oh, thank you so much, Ashley. Ashley, do you want to talk? We have a very short time left, and I would love to end this on a way to think a little bit about next steps and how we get past this. Do you want to talk really briefly about what you just shared?
Sure. So I'm not endorsing this tool. I don't think there's actually a very good tool quite out there yet about change management. But I think that's kind of what we're touching on here, where we've talked a lot about strategic and operational planning, but how do you actually make that change? How do you get people on board to build that plan and develop that plan? And I think between all of us on the panel here have years of experience facing many of the challenges that you guys have cited. And I think probably a newer one is this burnout. People don't even want to talk about COVID-19 anymore, but there is still a way to incite change. And so this is one of the few documents I have found on change management and public health. So change management is actually taught in business school, and it's really focused traditionally on how to bring customers and consumers and make changes in your business to reflect what the customers or consumers want. And so thinking about public health like a business, which pros and cons to doing something like that, but I think there are many attributes to change management that we could look at. And you'll see even in this brief document, again, not endorsing this as complete for change management, but it looks a lot about how do you bring in those stakeholders and how do you know who your champions are and who your blockers are, and doing that assessment as you're starting to think about change within your organization, change within your health system, change within your emergency response program. And how do you get those champions, and you spend a lot of effort and time with those champions to help promote your work? How do you address the blockers who you still need to pay attention to, but you may want to utilize in different ways? So there's a lot of information out there in the business world, and we're starting to think about shifting gears a bit in the way we teach emergency preparedness to really bring in this change management component, because again and again, many of the challenges you guys are citing, either in the breakout sessions or even in this plenary, are happening all over the world. And how can we make those changes? I don't necessarily have all the answers. And as I mentioned before, change management is relatively new in terms of being applied to public health. But this is kind of a component here where you can see on how people incite change and using that business model. And I would say for us, this is often the big blocker or obstacle to starting strategic planning, to starting operational planning, is getting everyone on board in your right groups together. And the stakeholder component is probably the most critical I have found thus far in trying to incite change within organizations or within a health system. I don't know, Jim, I know we've had some early discussions about change management some time ago, but I don't know if you have anything else you want to add.
No, and that's a great tool. I mean, like you said, not endorsing one, but it's the question was asked before about how do we make sure the right people are at the table, and then how do we encourage those who don't really want to be the right people at the table, and embracing things that are outside the quote unquote norm. I love, because there's a proven way in other places to do things like this, and why not use some of those methods? We can adopt anything we want to adopt, but using tools like that are important.
And I think coming back to, I think that the whole point of change management as well is, and thank you so much, Ashley, for sharing this, but thinking about, coming back to that question of having people involved and interested in the planning process moving forward. This whole idea of that this document that you shared, while I agree it's not the perfect and probably not the last tool we'll look at for this as a community, the idea of really thinking about communications and stakeholder engagement as part of this from the beginning, and getting people really invested in the planning process and committed to a theory of change. It is something that I think we're all going to have to learn a lot more about as we move forward. Because again, if people aren't really engaged right now in the idea of strengthening preparedness, we need to really do something to be motivational and get them to the table. So we are out of time. I would like to thank our speakers, our experts in strategic and operational preparedness planning. So many thanks to Ashley. Thank you, Dr. Greiner. Many thanks to Jim. Thank you, Mr. Banaski, and to Luis. Thank you, Mr. Hernandez, for your contributions to this. I would like to thank everyone who stuck through to the very end of this and who participated all the way through. You are the stalwarts and the strong people who are really so critically essential to the way we think about this moving forward, and really appreciate your time and your commitment. Thanks to all of you. Appreciate you being here today. Glad to meet you, and look forward to meeting you in future events at the CUGH event and at others. Thank you.
Bye. Thank you all.